just show you why. I think I showed some of you guys this last time we were here. But let's just look at his hammy, I'd say right about there, correct? That's about 45 degrees, give or take, correct? You guys agree? So if all I do is just distract his hip and relax.
Look at him stretch that hamstring.
Does that hamstring need stretched? So that's why we don't stretch hamstrings. Because usually they're not short or tight or what have you. It's something else. Okay? So that's just a kind of cool trick I work on my therapist with. So hamstring length, we showed you guys. Thomas test, you guys already know, so I'm going to skip those. The adductor test for length, there's 2 of them with the knee straight. Should be able to get out to about 45. He gets out there clearly. That's looking at the longest. And then I just have to take that off a little bit and look at the rest of them. And that to me is adequate right there. I don't think that's an issue at all. But yet I still see, you know, in the clinic, everyone doing all these, or go up to a gym, they're all stretching those bad boys, and the feet are out like that. I'm going, damn, if you need to do the splits, all right, then go ahead and stretch them. But normal people don't need. But the one that you want to look at is the piriformis. Now, this one's tough on guys because most guys don't have the internal rotation available to them to do this one. So the hip at 90, getting the knee to midline, okay, adduction, and then internally rotate, about 20 degrees. To me, that is considered normal. If I found that to be restricted, my first thought where I go is his hip or his sacrum. So I would not go around and just start doing ultrasounds and soft tissue mobilization and foam roller exercises on the piriformis. I'm going to try to look at his sacrum, fix that, and look at his hip. His hip may not have 20 degrees of internal rotation. He's close. I mean, it's not bad as we looked at yesterday. Hip extension was ugly.
And external.
Whew. What are we at? What do you guys think there? 40? 45? What do you think? Make a number. 30? Hey, man, I'm asking you guys. All right, 35 to 40. We'll go with the grade. So, scoot you. Can I spin you around since we looked at this hip? So we're going to do the 2 manipulations. You guys have probably seen this one. It's talked about in the clinical prediction rule. It's called a regional manip. I call it a Stoddard manip because it was first described by Alan Stoddard. I don't care what you call it. You can call it an AI manip. Okay? We're going to take the right or his left side and manip his SIJ. Okay? If it's anterior, we felt that it was anterior. We had a positive long sit test. We had a positive seating flexion test. We had a positive standing flexion test. We had 3 out of 4 of Cebulka's. We had a positive provocation test and a positive flick test. Now, he and I will tell you we don't do all those tests. But if that's what it says and it's screaming to you AI, this is a technique that you might want to use. Okay? It's pretty simple. We're going to side bend him. I like to side bend him until I see this ASIS move. That tells me that I've got his spine or his pelvis locked up. Okay? Then I'm going to side bend him again until I see this move. That tells me that I got his lumbar spine locked up. Okay? Hands behind the head, interlock your fingers. And this is the hard part. He's a bigger guy, I'm a bigger guy, so this is sometimes difficult to feather my arm through. So there's different ways you can do it. The most important component is maintaining this side bending. You hanging okay?
Mm-hmm.
Maintaining this amount of side bending, okay? But what I'm going to do is I'm going to I like to contact early just so it's not up in the air. I like to contact early. Where you contact is important because if I come out on here, he's not going to like that and I can't do my thrust. I like to take up that soft tissue and put the ASIS here, not on the carpal bone, but inside the carpal, in the palm. That allows me to be soft and soft to him. I am going to feather through. This is where the work comes in. Some of you may need to maintain this side bending, and you can see I'm going to rotate him until this ASIS starts to move up. Now I've got all the motion taken out. All I'm going to come in, I'm going to get my sternum high, my elbows straight, come down, and thrust. Okay? My little variation is, relax for me, is thrusting straight down there. I like to get in there and give a little bit there. So in real time, because I like to do this in real time, because sometimes if you hold them there too long, things don't work out, is I'm going to side bend them. I'm going to side bend them. We're just going to thrust through here. He's a real patient. Come up and thrust down. Didn't cavitate, don't care. I wanted to see if that changed. Yeah. Was he tight? Just food for thought. It's kind of cool, isn't it? So nerves are nerves, Golgi tendon, type 3 mechanoreceptors, all those things that she told us about yesterday, the things for manipulation, they affect all kinds of joints and muscles. So stretching, he might benefit from some hip stuff, maybe. But I'd work on his joints and get him mobile a little bit more, functional. I'd put him on the stick, which Troy's going to talk about later. Stick will kick his butt. You been on the stick yet?
Which one?
The stick flexion, hip hinge, or overhead stick squats.
Like this at the stand?
No, kind of. Yeah, you will see. All right, so let's do that.